This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the Neurosurgical Review, published in 2026. It's a pilot comparative study focusing on intraoperative results and surgical outcomes between asleep, awake, asleep, or AAA, and traditional general anesthesia, GA, modalities in temporal lobe resections.
This is a timely topic, Alara. We know that for patients with drug-resistant epilepsy, or DRE, surgery is often the best path forward. Specifically for those with mesiotemporal lobe epilepsy due to hippocampal sclerosis, MTLEHS, resective surgery can lead to seizure freedom in 40 to 65% of cases. But the big question has always been, how do we best balance maximum resection with the preservation of eloquent functions, like language?
Exactly. The paper notes that while general anesthesia has been the mainstay because it provides a stable surgical environment and patient immobility, it limits our ability to perform real-time functional mapping. That's where awake craniotomy, AC, comes in. The authors highlight that AC can improve precision in identifying and preserving critical brain areas, potentially leading to fewer neurological deficits and shorter hospital stays.
Right, but AC isn't a monolith. There are different modalities. The paper mentions monitored anesthesia care, or MAC, where the patient is sedated but conscious, asleep, awake, asleep, or AAA, and asleep, awake, or AA, where they don't resedate the patient after the mapping. This study specifically looks at AAA versus GA. Let's dive into their methodology.
This was a single-center retrospective case control study conducted at the National Institute of Neurology and Neurosurgery in Mexico City. They looked at 31 adult patients who underwent microsurgical resection for MTLEHS. Importantly, all these cases were ipsilateral to the language-dominant hemisphere.
That's a critical point for our listeners. When you're operating in the dominant hemisphere, the stakes for cognitive and language preservation are much higher. How are the groups split?
Out of the 31 patients, 20 underwent the procedure under general anesthesia, and 11 were in the AAA group. All patients had clinical, imaging, and neurophysiological concordant evidence of MTLEHS. The researchers were looking for differences in intraoperative hemodynamic and physiological findings, as well as postoperative outcomes, including the ILA scale scores at 1 year of follow-up.
And their primary hypothesis?
They hypothesized that there would be no significant differences in outcomes between AAA and GA. Essentially, they wanted to see if the AAA modality was just as safe and effective as traditional GA for these specific epilepsy surgeries.
Let's get into the intraoperative results. When we talk about awake mapping, there's often a concern about hemodynamic stability, surges in blood pressure or heart rate when the patient is woken up. What did the study find?
Interestingly, they found no notable differences between the groups in terms of hemodynamic parameters. They also looked at arterial blood gas measurements and blood loss. Again, no significant differences. The patients in the AAA group remained physiologically stable during the awake phase of the procedure.
That's reassuring. It suggests that with a skilled neuroanesthesiology team, the physiological stress of being awake during a craniotomy is manageable. However, there was one significant difference in the intraoperative data, wasn't there?
Yes, the surgery length. The surgery was significantly longer in the AAA group.
Which makes sense. When you're doing AAA, you have to factor in the time for the initial anesthesia, the emergence for the mapping and neurological evaluation, and then the reinduction of anesthesia to complete the closure. It's a more complex workflow.
Exactly. But the question then becomes, does that extra time in the OR translate to better or worse outcomes for the patient? If we look at the postoperative results, the study found that hospital stay duration and complication rates were comparable between both groups.
Let's talk about those complications and neurological deficits. In the context of dominant temporal lobe resections, we're always worried about language or memory deficits.
The paper reports that neurological deficits were minimal in both groups. Statistically, there was no significant difference. This is a vital finding because it shows that, at least in this pilot cohort, the AAA modality didn't lead to more post-op complications, despite the complexity.
And what about the most important metric for an epilepsy patient, seizure control?
They used the ILA classification system. Most patients in both the GA and AAA groups achieved positive results. Specifically, the majority experienced either no seizures or rare non-disabling seizures at the 1 year follow-up.
So if the seizure outcomes are the same and the complication rates are the same, but AAA takes longer, a skeptic might ask why we should bother with the AAA modality at all.
That's a fair question. The authors argue that while this pilot study shows AAA is comparable to GA, the real value of AAA lies in those cases where the lesion or the zone of resection is in very close proximity to eloquent cortex. The ability to perform real-time functional mapping gives the surgeon a layer of safety that GA simply cannot provide. They mention that AC techniques are well established in neuro-oncology for this reason, and this study helps bridge that gap into epilepsy surgery.
It's about the surveillance of cognitive functions. Under GA, we are essentially flying blind regarding the patient's real-time language status. The AAA modality allows for that psychological evaluation and interaction during the resection.
Right, and the study notes that the AC modality can actually shorten hospital stays and reduce the need for intensive care unit monitoring in some settings, though in this specific pilot, the hospital stay was similar.
We should also touch on the limitations. This was a pilot study after all.
Yes, the sample size is the biggest limitation, only 31 patients in total, with just 11 in the AAA group. Because of this limited size, the authors are careful to state that further evidence is needed to confirm the long-term benefits of AAA over GA in epilepsy surgery involving eloquent areas.
It's also a retrospective case control study, which always carries some risk of bias. But as a pilot study, it sets a very solid foundation. It proves the safety and feasibility of the AAA technique in a specialized center like the National Institute of Neurology and Neurosurgery.
To summarize for our residents and students, AAA anesthesia for temporal lobe resections in the dominant hemisphere showed comparable intraoperative stability and postoperative seizure control to GA. While the surgery takes longer, it doesn't appear to increase the risk of complications or prolong the hospital stay.
And for the practicing neurosurgeons listening, this might encourage a more frequent use of AAA in MTLE-HS cases where the anatomy is tight and you want that extra level of functional assurance. If you have the right multidisciplinary team, neurosurgery, neuroanesthesiology, and neuropsychology, the AAA modality is a robust tool.
The research really emphasizes that interaction during the awake phase. It's about that appropriate anesthetic emergence and the patient's ability to interact during the psychological evaluation that makes the difference.
Well, this has been a great deep dive into the 2026 Neurosurgical Review paper. It's always exciting to see pilot data that challenges our traditional reliance on GA and moves us towards more tailored, functional approaches.
Definitely. It'll be interesting to see if larger multi-center trials follow up on this to see if AAA can actually show superiority in certain cognitive outcomes rather than just non-inferiority.
We'll have to keep an eye on the literature. That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast.
Thanks, everyone. See you next time.